All right. Good morning, everyone. Welcome to the third in our menopause series from Healthcare Education and Training. Have no fear, help is here. Sexual health and menopause. We're so excited you're joining us today. Dr. Kurtzer and I are both coming to you from Illinois. So welcome and hello. Our A little bit of logistics as we get into the webinar. If you would like to use subtitles, you can see on the bottom of your screen, just click on the live transcript and that will help you be able to access closed caption. And that, if you need that, you can find that there. Next, please. For Q&A, we plan to do all of our Q&A at the end. So if you would like to ask a question, please use the Q&A button and submit it there. And we will have those ready for Dr. Kurtzer at the end of the presentation. The content's going to be amazing. Please feel free to enter any Q&A and we'll try to get to as many as we can. This is where you can find more about HCT. Many of you know that our work is centered around improving reproductive and sexual health, specifically in the Midwest. Our socials and our online presence are a little bit limited right now intentionally, but you can find us on Facebook and Instagram, and there's our website. And our learn.hct.org is where we do our virtual trainings. If you would like to learn more about those options, contact us directly. We currently do not have that available online. Next. We would love, love, love your help with evaluation of this webinar. So we're going to send you a link. Please complete that evaluation for us. We really do use the feedback and we share it with our presenters. And if you have any technical difficulties, we'll be monitoring this email here, updates@hct.org, so we can help you there. Nursing contact hours. So we're approved provider of nursing contact hours. To get those after this, please attend the entire webinar, complete the pre-post tests if there and evaluation, and send the nursing contact hour form to Kelly at kbradford@hct.org. Some disclosures. I'll read the first two to you and the rest you can peruse yourself. So no one in control of content of this activity has a relevant financial relationship to disclose except Dr. Tracy Kurtzer. She's the presenter today. She's on the Speakers Bureau for Astellas Pharma, Inc. and is a clinical advisor for Alloy, Inc. All of the relevant financial relationships for Dr. Kurtzer have been mitigated. The rest are for you. Yeah, perfect. Go ahead. All right, and without further ado, I would love to introduce you to Dr. Tracy Kurtzer. She is a clinical assistant professor and the medical director for trauma-informed care and education for the Department of Obstetrics at Northwestern Medicine, and she dedicates her whole career to providing highly specialized trauma-informed gynecology services, at the Center for Sexual Medicine and Menopause. She spends her non-clinical time working on hospital and healthcare policy and on training other healthcare professionals and others in the importance of trauma-informed and patient-centered care. She also educates clinicians on the underserved areas of women's health, including perimenopause or menopause, vulvovaginal pain disorders, and sexual medicine. And without further ado, I will turn it over to you, Dr. Kurtzer. Thank you for being here.
Well, thank you so much for having me today. And yes, help is here, and I'm so glad that all of you are attending. It's kind of the mix of the two favorite topics I love talking about, menopause and sexual medicine. In addition to the disclosures that Abby already discussed, I am a grandmother to the indomitable Aspen Soleil and a Cubs fan as we get into spring season here. For some of the objectives that we have set up for today, we're going to talk about the normal hormonal and physiological changes that happen in menopause that impact sexual health. We're going to review so you have a better understanding of when to request an evaluation for sexual dysfunction and what to expect during that exam, and then be able to effectively communicate with your healthcare professional, having some basic knowledge about some of the different treatment options that are available and kind of the why behind why these different treatments are available. To go back, I would just like to start on definitions because I know this is part of a series of menopause, but just to review for those who might not have been at some of the earlier sessions, when we're talking about menopause, it's that normal natural event that is relate as the cessation of the menstrual cycle for a period of 12 consecutive months, and in the absence of any other obvious cause, like medical reason or whatnot. The other definition includes non-spontaneous, when there's been either due to surgery or chemotherapy or whatnot. If there's other reasons why the ovaries are no longer producing hormones, then that would be, of course, also menopause. In the presentation today, when I use the term women, I'm going to be using that as a term when I'm just directly copying studies, and that terminology has been used. However, I do want to just remind people that the concepts and symptoms of menopause are going to apply to any individual of any gender identity who has ovaries. And then for that reason, I will try to typically refer to those individuals as menopausal patients or a person with ovaries, for anybody who's going through this change of life. And change of life, I put that specifically in because you'll sometimes hear people talking about that, right? Like our moms or grandmothers talking about when they went through the change or change of life. And we're talking about perimenopause, menopause transition, menopause. So just to give a little terminology here too, menopause transition is when there is the beginning of some of these changes happening in our body with hormonal changes that lead to changes in the menstrual cycle length. And typically those changes are going to be 7 days or more between cycles in, again, consecutive cycles. And then later, menopause transition, that's kind of the earlier phase, is when we start getting into actual like missed periods altogether, complete spacing over 60 days and more consistent elevations in some of the hormone markers that we use for menopause, particularly FSH or follicle stimulating hormone, starts to really creep up and stay up in a more sustained way. Perimenopause includes that period before the last menstrual period and up to that full year afterwards, when again the definition of menopause is. So menopause that year out, that's when we're going to certainly see some elevations in FSH and loss of menstruation. And that's really when the symptoms of menopause that are most obvious, like vasomotor symptoms, are most likely to occur, but they really can occur at any time in that period. And then in later menopause is when we really start seeing some more of the impact of the sexual health piece of it. So what are some of the, immediate health impacts? There's a lot of the physical symptoms and psychosocial effects as well. And then long term, being in menopause for some period of time, there can start to be some distinction and differences in heart disease rates, bone health, like osteoporosis rates start to pick up, cognitive decline rates might start to become more obvious, and then sexual health issues start to pick up as well. And that's what we're going to focus on today as far as the physical symptoms, sexual dysfunction, but those sexual dysfunction does play a role in some of the psychosocial piece of menopause too. So the impact on relationships, the impact on life satisfaction, some of that ties back to some of the sexual dysfunction that can happen during this time period. And why is sexual functioning important? Well, it's a vital part of many of our lives. It's not for everybody, but for most people, sexual function creates intimacy, it creates pleasure for us, it's part of our quality of life. And it is present throughout our entire lifetime potentially. There is certainly some decreases with age that can have to do with some of the sexual dysfunction concerns that it will talk about, but also sometimes it has to do with just, partner availability. Women do tend to live longer than their male counterparts, so sometimes it has nothing to do with sexual dysfunction, but just, availability of a partner. When sexual function is disrupted, it can cause significant emotional distress and relationship issues. And when we talk about prevalence, this is a really important study done by Jan Schifrin called the PRESIDE study. This was a self-reported survey of women just reporting if they had problems in any of the main domains of sexual functioning, desire, or sometimes people refer to libido, arousal, and orgasm. Like, do you have problems in these areas? Is it working the same as it did before? And 43% of all women between the ages of 18 and 100 said that they had some level of a dysfunction in one or more of those areas. But that number bumped up to 60% for menopausal women. Now, for um, diagnostic purposes, when we're diagnosing female sexual dysfunction, we do look also at not only is there a dysfunction, but is it causing distress for the person? So those numbers are a little bit lower, as you can see in this graph. But overall, sexual, function issues are quite prevalent for all of us. So definitely, if you're dealing with any of those, you're not alone. And, the question comes up with menopause, since it does pick up after that point, is it because of the hormones? Is it because of the brain and neurotransmitters? And what I would just say to you is it's a little bit of both. It can be, for both reasons. The hormones are really important for preparing those parts of our brain so that they can respond appropriately to the neurochemical signals, but also play such a critical role in the genital area. How are our genitals going to respond to sexual stimulation and those nerve impulses? And then at the neurotransmitter level, those neurochemicals have both excitatory and inhibitory properties that mediate all of the different domains again, desire, arousal, and orgasm. And I don't expect any of you to memorize this graphic, but it just really is here to show to you in the central part of the brain when it comes to desire, arousal, and orgasm, and all of those signals that have to happen in the brain area, that our hormones are important, estrogen, testosterone, and progesterone. But if you look at it, also those neurochemicals, right? The dopamine, 5-HT or serotonin, norepinephrine, and then some of the other satellite hormones like prolactin and oxytocin also play a role. And then in the peripheral area, at the tissue level, the genital tissues and the organs like the ovaries and adrenal glands that create the hormones, basically those hormones are really important for the normal development and tissue health, blood flow coming to the vaginal and clitoral tissues. But also, again, those neurochemicals, those neurotransmitters play a role in vasocongestion and the sensory stimuli that are needed. So it's all very integrated, and that's why as we age in menopause, because of all the different factors that can play a role, we are at higher risk for female sexual dysfunction. It's hormones, it's the neurologic system, and it's also the body parts and anatomy. So we're going to talk about the different areas, and I'm going to kind of follow based on prevalence. We'll start first with low libido, which has like higher percentage effect, and then arousal and orgasm issues. And then last, we'll talk about pain, sexual pain. And let's talk first, focus a little bit on the hormones that are involved. So hormone deficiencies in estradiol, progesterone, and testosterone. And again, that can be either spontaneous, natural menopause, but also can happen sometimes to women because of surgical procedures, like having the ovaries removed or a BSO, even sometimes in younger patients who've had identified BRCA mutations, or maybe they had to have a tumor or endometriosis. So whenever that hormone deficiency starts, these are symptoms that can result or the impact. Also, iatrogenic, like I mentioned, chemotherapy, sometimes post-viral illnesses as well. So that deficiency can lead very often to about 80% of us to vasomotor symptoms. And vasomotor symptoms, things like hot flashes and night sweats, can disrupt our sleep. Disrupted sleep leads to low energy. And also, when we have disrupted sleep, it's going to decrease the stimulation of the sex drive centers in the brain. In addition, if we have these hormone deficiencies, we're going to have some metabolic changes that can lead to weight gain. Sometimes that can affect also our body image and how comfortable we're feeling about being sexual beings if we're not comfortable with how we look or present. And then there can be direct effects on arousal, that really important component of needing engorgement of the clitoral and vaginal and vulvar tissues that enhances normal lubrication of those tissues and contributes to normal orgasm as well. And if they are deficient, you'll have issues with normal arousal and also issues with some of the dryness and atrophy or thinning of the tissues that can lead to pain with intercourse. And all of these really point to how hormone deficiencies can contribute to low libido, even if it's not like the direct effect of testosterone on the brain, which, it can be, and that's why I have low testosterone there. But that's actually one of the more minor causes for low libido. Actually, what we see more commonly is those other impacts of the hormone deficiencies, the not feeling comfortable in our bodies, the low levels of energy impacting, what we have to, caloric intake we have or outtake we have to engage in sexual activity. It's going to really shut down that part of our libido centers when our brain recognizes you're exhausted, you don't have energy to engage in this activity. Painful sex, incredibly common, and diminished orgasm, right? If you're not having kind of that positive feedback loop to the brain, that part of the brain's going to shut down as well. So these are all ways that hormones can impact low libido. Now, you may hear the term sometimes also relayed hypoactive sexual desire disorder, which is a very specific term, HSDD, which is determined through history or a screener like the DSDS screener, basically is eliminating all of those other factors. So if there's really no other reason, like the things that I just went over, for there to be inhibited libido, then somebody may have a primary disorder of hypoactive sexual desire disorder. And we look at that as kind of a subset of low libido, but it's a smaller percentage. So if you look at kind of low libido rates overall based on age, that picks up as you get older, And again, because of all those factors, the hormones, the neurotransmitters, and brain component, whereas HSDD is fairly consistent, throughout the ages generally. And so how that is treated when we get to the treatments can be just, there's some distinctions there. I'm going to switch gears now and we'll go to arousal disorder. And just to have everybody on the same page, arousal is basically that sense of sexual pleasure accompanied by physiologic changes. So there's some changes in our vital signs, our heart rate, respiratory rate, and blood pressure go up. But what's really pertinent to this talk is the anatomic changes. There's engorgement of the genital tissues, specifically the vaginal and vulvar tissues swell, they get engorged, that enhances vaginal lubrication. And then there's also engorgement of the clitoral structure. Sexual arousal disorder, which is known by the acronym SAD, is basically the inability to achieve or maintain sexual arousal with lack of genital lubrication or swelling. And some people also report that as feeling like there's like a dullness or lack of sensation. And the prevalence runs around 10%, with about 7.5 reporting distress with it. Again, pick up about a doubling as you get into the older age groups. And again, you don't have to remember all of the factors, just to remind us that yes, hormones do have a role with kind of the tissue preparation in the area. But in this case, really neurotransmitters are really critically important for having the normal excitatory effects on the mechanics that have to happen for vasoconstriction, vasodilation and engorgement to happen. And then last, orgasm, basically a sensation of intense pleasure, creating an altered consciousness, and that's accompanied by these physiologic factors that happen: uterine contractions, pelvic floor, and anal contractions. It resolves that feeling of engorgement and induces just a sense of overall well-being. Female orgasmic disorder, or FOD, is the persistence, not just one-time event, but if it happens recurrently, of a delayed or absent orgasm, even when there's normal arousal in place. And again, the clinical definition requires some type of distress or interpersonal difficulties as a result. And this one really requires quite a bit of brain involvement and neurotransmitter. This just goes to show some of the areas of the brain that are involved when there's stimulation of the clitoris and cervix and vagina that are happening during orgasm. And there is direct roots, this like intact spinal cord is really important, those connections to the brain, as well as some looping connections that go to the vagus nerve and through the pelvic nerves too. So you may have heard of vaginal orgasms as well as clitoral orgasms, and some of that has to do with some of the neural connections. So to have normal orgasm, we must have intact neurologic systems and vascular systems too. Again, you have to have that arousal preload to the clitoris, and then all of those nerves, 8,000 nerve endings present in the clitoris that are important for sending signals through the spinal cord to the brain. And I just want to also let people know there is another important hormone involved here, oxytocin, which many of you may have heard of if you were ever in labor and delivery and being induced with Pitocin. That's another name for oxytocin. Oxytocin is the natural hormone basically secreted from the posterior pituitary. It is secreted during normal arousal and orgasm, and it really helps with promoting those muscle contractions. So when there's inhibition of oxytocin, there may be inhibited orgasm response. And again, arousal, female arousal disorder, we see almost a doubling of the rates of this being a problem as we get into the menopause, perimenopause, and menopause years. And last, there's sexual pain disorder, and about 14 to 15% of women up to the age of 60 report recurrent pain with intercourse. I think that, number, of course, increases as well. But I did want to just let people, I guess, bring an awareness as to how common this actually can be in our younger patients as well. And that's because of the huge variety of causes for pain with penetrative sexual activity. So estrogen deficiency is certainly one potential role, and that's what really impacts our menopausal patients to a degree. But our menopausal patients may also be coming into menopause with some of these other conditions, and our younger patients may have these as a primary condition. So we have to keep in mind when we're doing evaluations all of these different things from vaginismus or pelvic floor tension, vulvodynia, which is more of a nerve dysfunction pain, dermatologic conditions, infectious conditions that are causing vulvovaginitis, and then, some of the rare conditions that can cause superficial pain, and then very common deep causes of pain, endometriosis, pelvic floor tension, pelvic inflammatory disease, and some of the inflammation and scarring that can cause. In our menopausal patients, pelvic organ prolapse, where there's dropping of the organs that can kind of increase pain with penetrative activity. So, ovarian tumors, fibroid tumors in the uterus. So there's a whole host of different things that we have to keep in mind when dealing with sexual pain. But again, in our menopausal patients, if if their hormone deficiencies are not being addressed, very, very commonly, and this can be progressive over time. So this is one of those things that has more of that kind of wear and tear effect from the deficiency of the hormone over the years. You're going to get progressive thinning of those vulvar and vaginal tissues. And you can see on the left kind of normal thickness with a lot of cellular layering. Those cells all are the ones that are going to be producing those lubricating substances. And then you can see how there's kind of a microscopic fold in the tissue, which helps with some of the accordion nature of the vaginal tissues. Whereas on the right side, after menopause, the tissues are much thinner. And very importantly, we lose that mobility, we lose the elasticity. And those changes not only are happening at the vaginal level, and you can imagine with friction over the surface, when that happens, that can lead to not only the dryness from lack of lubrication, but also little microabrasions or lacerations in the surface that can be incredibly painful. It can feel like ground glass, sandpaper kind of feeling. So that's going to be really inhibiting of wanting to engage in sexual activity if you're having pain like that. But in addition, sometimes these changes are also affecting the lower urethra, and that can increase risk for urinary tract infections. So we see higher rates of painful urination and UTIs in peri and postmenopausal women. And again, that can be such a powerful disinhibition to the brain to want to engage in penetrative sexual activity. The same tissue features can happen in the clitoris. So there can be atrophy and shrinkage of the clitoris that makes it much harder to stimulate and decreased orgasm. And again, you're getting kind of that lack of the positive feedback loop to the brain of normal orgasm and some of the pleasure responses that that brings. And then you also can get some of the negative connotations with that frustration feeling, shame that orgasm's not working anymore, distress in the relationship. So all of those can be, again, negative feedback loops to not want to even engage in that activity because of the experiences from before. Over time, with progression and particularly severe cases, there can actually be from that loss of elasticity and lack of regular penetrative activity, there can actually be some closing down of the, or like constriction of the diameter of the vaginal canal. And then as we get older too, we're more likely to also face some dermatologic skin conditions that can also sometimes lead to vaginal stenosis. And there's also a condition that I always just like to highlight because it's just really not understood well or known about, and that is the term that used to be called vaginismus. Now we try to use the term genitopelvic pain penetration disorder, which is basically persistent difficulty with vaginal intercourse or penetration. And so what that means is it can apply to other things that might be going in the vagina, like when you have to have your gynecologic exam and you have a very painful speculum exam, or tampon use for younger patients who are trying to learn how to use tampons. And this used to be called vaginismus, which really kind of applied to some of the muscle spasms that can be seen with this condition. But having muscular spasm is not a requirement. It can be pain for whatever reason, or lack of ability to have penetration for whatever reason, or it can even just include fear or anxiety about pain and anticipation of intercourse or penetrative activity. This is a condition that can be very often is acquired. It can be result from having severe atrophy that's gone to such an extreme level of pain that there's actually quite a bit of muscle tension or fear surrounding sexual activity. But it can also be lifelong. This can be a problem that some individuals can have for their entire life. And the reason I like to bring it to attention of a group, because some of you may be dealing with this and not know of it, or if you're taking care of patients yourself, it's really important because each act of or attempt to have penetrative activity is typically going to worsen the pain, and it's going to create a compounded problem. Individuals who have this have very, very high levels of both sexual and medically induced trauma. Trauma reactions are super common during exams. So if you're doing exams, being aware of this condition and how triggering it can be. And because of that, it really requires somebody who's skilled or at least knowledgeable of this, about this condition, to really do these evaluations in a systematic way to not contribute to the compounded trauma and pain. Treatment for this condition actually is very intensive. It requires a multidisciplinary approach to treatment that would include your, OB-GYN to do the physical treatment part, very skilled pelvic floor physical therapist, sometimes a skilled physical medicine rehab doc, and then the talk therapy piece of it, right? Because it becomes very much a mind-body connection condition. So a skilled psychotherapist as well. So I just wanted to make you all aware of that. And at this point, I just want to go over like what a typical evaluation might look like. So if somebody's coming into our office, like what is happening here? And the first part is getting, the diagnosis. So screening questionnaires can be used, and um, I would say questionnaires are important, but even just talking about it. And what we know, unfortunately, from surveys is that even though sexual activity, whether self-stimulation or partnered activity or penetrative activity or not, but sexual activity, as we know, is continuing in the upper age group, so menopausal patients, and they are engaging in sexual activity. Yet only 22% reported that they had discussed sex with a physician after the age of 50. So these conversations are not coming up enough given how important it is, and relevant it is, I would say, to our lives. And one approach, again, is just asking, many of our patients have sexual health questions or concerns. Do you have any concerns with your libido, with how you lubricate, or your response to orgasm? Do you feel satisfied with your sex life? Are you having any pain? So it can be as simple as just screening like that, or you can get, more technical and really help with formal diagnosis, again, using like that DSDS screener I mentioned before, which helps to determine if somebody maybe has just low libido versus HSDD, or a more extensive questionnaire, the FSFI, or Female Sexual Function Index. It's more extensive. It covers the 6 different domains of sexual dysfunction. It's 19 questions. It's also a validated screening tool. And so it really depends on how you would want to go about that. Or for for yourself, you can certainly pull those up online and do the questionnaire. But then the next step is figuring out what's going on again, hormonal status, and thinking about those neurotransmitters and the brain component. And the conditions that really can impact those areas the most are our medical conditions and medications. And so when we look at, different like hormonal states, sometimes that's just, from spontaneous menopause, but sometimes low estrogen and low androgen states are because of medications that are being used, anti-androgens. Like I think a lot of people are on different medications like spironolactone for hair loss is commonly given, birth control pills for our younger patients who are needing contraception, like those can actually inhibit normal hormonal factors. And then again, really pertinent as we age are some of the medications that are used to treat diabetes, high blood pressure, neurologic conditions that can start to come up, and some of the treatments for that, cancers, and some of the treatments and chemotherapy, medications, and radiation, and those impacts. Just our emotional health, depression, and stress levels, and how that affects our dopamine and serotonin systems. And then if we're treating with some of those medications to treat depression or anxiety, how can they be impacting? And then our, psychosocial issues, other stressors, relationships, and things that can play a role as well. So we really can get into the weeds as far as a lot of details, particularly because as individuals age, they are going to have more medical conditions and more medications to kind of ferret through and figure out what might be playing a role here. And then last is the genital examination or sexual health examination. And of course, the focus is going to be on the genitals and pelvic organs. And so with that exam, we're looking at the tissue health. Do the tissues look nice and pink? Are there any dermatologic conditions that we might be dealing with? So if we're seeing rashes or changes on the skin on the outside, changes to coloration of the skin. And then we also want to see, are the nerves functioning normally? Are the signals coming from the brain through the spinal cord into the nerves that supply the external genitals, particularly the pudendal nerve? Are they getting signaled correctly? And that can be done by using a test called a Q-tip test. So if you're having this evaluation and the doctor's pulling out a Q-tip and saying, I'm going to poke around a little bit, we're actually testing some of the different dermatomes where the nerves supply the skin. So we can see, is there any lack of sensation in any areas? Or is there any over sensation? Sometimes pain is a neurologic disorder too, and there can be hypersensitivity, but that can be a marker that there's some neurologic problem going on. So Q-tip touching around the skin structures on the outside, all the way into that entrance area, right around the vagina, that pink area that incorporates the urethral opening and the vaginal opening is called the vestibule. And that is a very common area for both physical changes of atrophy to be evident and neurologic dysfunction to be evident that is picked up through using a Q-tip and touching. And then there's a very, important exam to be done around the clitoris. And we often forget that the clitoris is not just that little bump that we're aware of on the outside, which on this diagram, right, is the glands of the clitoris. And I'm sorry, I just realized that the text in this is not in super good um, clarity, but the glans is the little rounded structure at the tip that we can see and feel. But there is a whole body of the clitoris that goes back up under the pubic bone and then splays out on either side. And those areas play a role too. And as you can see, the vascular supply and the nerve supply come down on that anterior part or top part of the clitoris. So doing Q-tip touch testing and sensory testing using temperature around the top of the clitoris on the outside lets us know, is there neurologic dysfunction? Can we even see the clitoris, or has it maybe been obscured because it's gotten so small and atrophied? Or has there been any scarring or inflammation from a dermatologic condition? So that's why there's a lot of detail placed to the clitoris, more than probably any other exam you've ever had, because that's not an area of a lot of focus when you go in for like your annual exam and pap smear. So doing that exam really important, particularly in individuals who have orgasmic dysfunction. And then while all of that's being done, we're paying attention to the muscles. There's the muscles that circle around the entrance of the vagina. Are they spasmed and contracted, or the opposite? Are they showing signs of relaxation and lack of tonicity? Both of those conditions, either overly tense or over relaxed muscles, can play a role in sexual dysfunction, both orgasmic dysfunction and pain disorder as well. And then with the internal palpation, we're of course palpating the uterus and ovaries like we would normally do for a screening exam. But in this case, we're just looking for conditions like prolapse, or is there any, tumors or enlargement that maybe would be a culprit for somebody who's having deep penetrative pain. But really importantly, we're also palpating that hammock of muscles, those pelvic floor muscles that kind of hold all the organs up in place, to see, are there any areas that are banded or tense, or again, overly relaxed, that might be contributing to issues related to normal orgasm response. And so once all of this information is put together, and so you can see why this isn't an appropriate exam to do at something like an annual exam, or tagged on to the end of a problem visit for a yeast infection or something, right? Like, this takes a lot of time. It's a very detailed history and exam to come up with a diagnosis and treatment. And Also, oftentimes there's overlap too, like there may be combinations of libido with other sexual dysfunction there. And part of that as well, the reason libido really cross covers with a lot of other issues is just because of such a huge interplay with hormone deficiencies, with having inhibited drive centers because of medications or medical conditions, and inhibited drive centers because of painful intercourse. So they really overlap quite a bit. If we have somebody who's having hormonal deficiency symptoms, and we want to improve their sleep and energy and weight, as you remember those, those factors from that earlier graphic. Menopausal hormone therapy is our first line go-to now. It's really what we should be considering first and foremost for our patients, unless they have contraindications to hormones. Um, if they do, if hormones are not appropriate for them or they're choosing not to be on hormones for whatever reason, then we do have some other options for menopausal patients. An SSRI called paroxetine at 7.5 milligrams and a medication called fezolinetant are both FDA approved for treating low libido, and those work basically in the central parts of the thermoregulatory centers of the brain to prevent vasomotor, inhibit vasomotor symptoms. There's also off-label use to try to stimulate libido of medications like testosterone, gabapentin, oxybutynin. Testosterone's up there twice. Don't know why that is. It's not doubly important, but it just, other non-medication things like doing procedures, stellate ganglion block, CBT or acupuncture, or um, using some of the herbal remedies that are out there, including up to CBD and marijuana use. So of course, all of those would be off-label approaches to trying to maybe help with hot flashes and night sweats caused by hormone deficiency. For painful intercourse, we'll go over in more detail some of the treatments for atrophy, genital urinary syndrome of menopause is the term for that now. We can treat those, pelvic floor muscles, and we can treat certainly any conditions that have picked up, like the dermatologic conditions or vulvodynia. And then to treat inhibited drive centers that are not due to hormonal deficiency or, some of the sequelae of that, talk therapy, and I put HRT there. It's kind of a joke. It's but not hormone therapy, but we often say sometimes that we have people who have normal libidos with one partner and not with another. So that's kind of a joke for husband replacement therapy. Or partner should be really PRT, partner replacement therapy. Psychotherapy, certainly if there's, mental health issues or trauma histories that need to be addressed. Looking at those medications again, is it possible, can we maybe switch somebody to a different medication and discontinue some of those inhibiting medications, the big players being blood pressure medications, the psychotropic medications like SSRIs and SNRIs. Alcohol intake can certainly contribute as well to some depression there. And then again, those medications, if there's really just inhibited drive centers and no other explanation, some of the medications for hypoactive sexual desire disorder, the FDA approved ones, flibanserin and bremelanotide are available. Flibanserin is an oral medication, bremelanotide is an injectable medication, and then off-label use of some other medicines like bupropion, which is an antidepressant, testosterone, again, a hormone that can help with that, or DHEA suppository form has also been shown to help with inhibited libido. And treatments for arousal disorder, again, focusing on, different non-pharmacologic approaches. Sometimes it's just a little bit of a training and getting those parts of the brain kind of turned back on. But again, the role of medications and both hormonal and neurotransmitter play a big big part in arousal disorder. So what about estrogen? Well, there is limited data, but overall, there are suggestions that vulvar sensitivity is reduced when there's estradiol deficiency, even if there's not pain. So it may make sense to make sure that somebody has estrogen therapy or local estrogen therapy to the vulvar and vaginal tissues, even in the absence of pain. DHEA, which is not an FDA-approved approach, but basically DHEA is a hormone that is produced in both the adrenal glands and the ovaries, and that hormone is metabolized into androgens and peripheral tissue. So testosterone and dihydrotestosterone and estradiol are all metabolites of DHEA. And one study of using DHEA in a vaginal suppository did show improved arousal using the FSFI study. And then a non-FDA approved use of sildenafil, which is a phosphodiesterase type 5 inhibitor. Most of us would recognize this as like a Viagra class of medications, but particularly sildenafil of those. And basically that works through utilizing the channels and the relationship of nitric oxide to sexual arousal and having vaso engorgement and the role that that plays, particularly in clitoral function as well. So there's controlled and uncontrolled studies. It did increase arousal scores, but it didn't increase as much when there was HSDD. The particular subgroup, however, that this really was helpful for are individuals who are on those SSRI medications to help with like depression or anxiety. So something that we do use to help with this condition in a subset of patients. And then for orgasmic dysfunction, again, huge role again with those medications. So I won't belabor that, but just discontinuing or changing some of those contributing medications. Just enhancing the nerves and how they're responding. Using vibrators or clitoral stimulation devices can actually benefit patients where there's been maybe, kind of a shutdown of the nerves in that area or not a lot of activity for a while. PFPT stands for pelvic floor physical therapy. So again, if identifying either overly relaxed or overly tense muscles that are going to inhibit normal orgasm muscle contraction response, we want to get those physical therapists involved. We do want to treat clitoral atrophy in this case. We want to make sure that there's good blood flow and that the clitoris needs to kind of be out there to be stimulated easily. Two approaches, again, not FDA approved, are DHEA vaginal suppository and the PDE5 inhibitor, again, the sildenafil. So kind of the same concepts as I just went over with arousal disorder for how those work. But again, really we have no FDA approved treatment for orgasmic dysfunction in women. So even use of testosterone is not an FDA-approved therapy, but there is some evidence out there that testosterone may be helpful for a variety of female sexual dysfunction. So I want to go over a little bit of the data behind that because it is certainly much more prominent in the news today and in treatments. A lot of patients are seeking testosterone or androgen therapy to help with sexual function. And so I think it's important to have a balanced perspective of the role of androgens by understanding, some of this information. So we know the correlation between androgen levels and overall sexual functioning is weak. There's no particular level that's predictive of low sexual function. There is some evidence that surgically menopausal women can benefit from treatment, but that's a subset of individuals. And basically with the meta-analysis though, there was recognition that testosterone can help sexual functioning in a variety of areas, orgasm, arousal, and certainly libido as well. So I think in the appropriately handled patient, postmenopausal patient, testosterone is appropriate. It just needs to be monitored very closely. And then last, painful intercourse. A lot of different approaches. We've already talked about a few of them, but treating the hormone deficiencies using a variety of products that are out there. And if somebody has stenosis, working with vaginal dilators and physical therapy can be really helpful. So these are just kind of jokes about some ways to treat female sexual dysfunction in menopause. And of course, those are acceptable choices, but hopefully now there are some different options out there. And I'm going to just quickly pass through the next few slides that I have because I would love to leave some time. I just was going to talk a little bit about long COVID and how that can impact sexual function as well. But I wanted to make sure to leave some time for questions, and you will also have access to the slide presentation as well, which will have my contact information. So actually, I can put that back. No, I will go for it. Yeah. So I don't
Okay.
know.
The first question that we have is, are there any tips for how to decrease belly fat in normal weight patients, BMI, um, BMI 25 or greater than 25? Um, I have several patients who fit this profile, and they report that shame, embarrassment over their belly fat, and their total inability to lose the belly fat affects their sexual life.
Right, right. And I think you probably really specified the BMI because what you're kind of alluding to there for maybe others is that these may be patients who don't qualify for some of the other um, prescription medications that kind of address the metabolic factors and can help with weight loss in a more rapid way. So they may not have access to those medications. And in our perimenopausal and menopausal patient, weight gain is such a huge concern and huge problem, and yes, impactful for sexual health, as I mentioned. And the approach that I would say I take with those patients, again, is if they're appropriate candidates for menopausal hormone therapy, I do think there's some added benefits to normalizing those hormone levels. It's not as direct, and I never want to give the impression that if you start on hormone therapy, suddenly, the pounds and the belly fat's just going to melt away. But it does help make us a little bit more efficient metabolizers overall. And in earlier studies, hormone users did tend to maintain their weight better than non-hormone users in menopause. But the other thing I would really point to in this, and it's applicable for both using hormones, but also just treating vasomotor symptoms, is the huge role that sleep disruption plays in this. If you think about it, if we have chronic sleep deprivation, and this is a time period where it happens for sure, our bodies, our brains are going to sense that we are in a low level stressed state. And we are still wired like ancient people. And so ancient people, when our bodies were sensing stress, when our brains were sensing stress, that usually referred to impending food shortages or current food shortages. And so our whole metabolism mechanics switch over into becoming little battery packs to try to preserve fat on our bodies so that we are going to survive that food shortage. So we have to address the sleep, whether that's through treating those nighttime symptoms, vasomotor symptoms, with hormones or with some other type of a sleep therapy. That I think is such a key piece to this. When people are sleeping better on top of that, in addition to this brain factor, we have more energy. We're less likely to, grab the cookies out on the table at the break room or whatever, just to kind of give us those short-term bursts of energy. So overall, addressing sleep is going to be a key piece. And then for the patients that are of higher BMIs or have some health issues, maybe precursor to diabetes, high blood pressure, whatnot, that need to be treated, those may be appropriate candidates for considering, like some of the other medications that are out there, the GLP-1 types of medications to really hit the belly fat as well.
Thank you. Next question we have is, generally it's felt not to initiate HRT for more than 10 years after menopause occurs. What recommendations would you have for someone who is only now complaining of decreased libido 10 to 20 years post-menopause?
Yes, I think again, you'd still go through some of those other, factors. You want to see, is there anything going on? Depression, anxiety, relationship, pain. I would say somebody that's over 10 years out, if they haven't already, and they haven't been on hormone therapy, presumably, by the question, that there probably is some component of atrophy or pain, and that could be a way to maybe enhance sexual functioning in a positive way. So again, if there's more sensory positive responses, if potentially there's more opportunities for orgasm by local hormone treatment, that is again going to be a positive feedback loop to the brain to try to reinitiate libido centers naturally. But again, this may be another patient if they don't have any other things to address, that using maybe one of the two therapies that's out there that you can try, just basically kind of trying to look at it kind of like a kickstarting of the libido centers that you can initiate in healthy postmenopausal women. And um, role of testosterone again. I think there's a lot that we need to learn more about. Is that maybe an appropriate approach to take for these patients? These are patients that will sometimes do trials of bupropion as well. And last I would say regarding the 10-year rule is I really use that as I don't think you have to have that as a hard and fast rule. I think with appropriate, counseling with a healthy, active non-smoker who doesn't have underlying cardiovascular disease, normal, cholesterol, or maybe has even done some additional screening or testing, that I think we need to maybe have a little bit more of an openness to using hormone therapy outside of that window if the benefits that that person gets, potentially outweighs their risks based on, who they are. So I would just say, individualize that as opposed to using that as like a, concrete rule that's unsurmountable.
Thank you. We have a question about if this was recorded and if the slides will be shared. This webinar is recorded and will be uploaded to our YouTube within the next week, as well as the slides were sent out previously to the start of the webinar, and I can include them in that follow-up email with evaluation and all that good stuff. So be on the lookout for that. And then the next question is, how much are providers prescribing flibanserin in patients with low desire in recent years? I believe it was initially approved for premenopausal women. I'm a mental health provider, sex therapist, so I'm approaching it from that perspective. Curious if it has been effective for post-menopausal women in any way.
Yeah, and again, I think this is where even when it was approved for premenopausal women in a healthy, appropriate postmenopausal women, there was certainly some off-label use of it. And I don't think in general, we're talking about an area in women's health that is very under treated, right? It's under-recognized and therefore under-treated. So I do not believe that there's been a boom in, flibanserin prescriptions in recent years, even with some expansion into postmenopausal women, since they, as we saw from the, graphs, they are really compromising a lot of the patients that are dealing with HSDD and low libido in particular. So, yeah, I would say that to answer that first part of the question, I don't think that it's used as much as it should be offered as an option for, somebody who can take it at night, who is not, we're not concerned about having low blood pressure or falls or getting overly sedated from it, based on their other medication profile. So keeping it in mind, I think, is good, having those conversations, patient-centered care, because it can be effective. Some of the original data showed that the increase in sexual experiences, it wasn't mind-blowing. Like, you would read that number and say, well, that doesn't seem like it's really making a big enough difference, but it really does. Even sometimes just an additional sexual contact experience with a partner, once a week or even once a month, can make a huge difference in a relationship and feeling, good about oneself, and feeling better about oneself sexually. And I think it also just provides, like I said, I often think of it as like a Kickstarter, right? It sometimes just is that little burst that somebody maybe needs to kind of get back into the habit and thinking about sexual activity, that then can kind of build on itself, and incorporating treatments for other, conditions that might have coexisted at that time. Were there other, relationship stresses that need to be dealt with, couples therapy? Is there some pain and dryness that we can take care of? So very often what we find is these conditions are very intertwined, and it's a multifactorial approach to helping. But so I do think there's a role for flibanserin for sure.
Awesome. And then we have one last question before we wrap up today. I understand that it is noon, so if people have to jump off, that is perfectly okay, but we will get this last question answered. So how long can someone stay on HRT? I hear people say things like for the shortest period possible or 1 year. If HRT is effective in treating so many of these problems, when we take it away, won't it recur?
Yes. Yeah. Um, so there is no set endpoint for hormone therapy. Basically, it's kind of the way we recommend it here is it's a year-to-year kind of check-in and reassessment. Now, very often things come up in life that preclude ongoing use. So sometimes that decision is made because somebody develops a blood clot or breast cancer. And so, of course, in those situations, because of medical conditions, they may have to come off of their hormones earlier. But assuming there's no, contraindications to continued use, and if somebody feels like they're getting these benefits to their quality of life, but also bone health and potentially, heart health as well, then absolutely that prescription can continue year after year after year. Now, you may have to modify it a little bit. Sometimes we don't need as much hormone therapy in our older years as younger menopause years. So it's just having somebody that's working with you on that, and kind of doing that reevaluation every year. To answer like the second part of that, yes. So if you come off of it, that is a discussion that would need to be had with the patient at that point, which is there may be changes then that start to happen at the tissue and genital level in particular that we should address coming off of systemic hormone therapy. And that is absolutely the appropriate person if they're not already doing local estrogen or DHEA, particularly like if there's more libido issues as well. You can kind of guide therapy to cover multiple bases again, but you definitely want to make sure that you've got good tissue health sustained so that they don't over the years start to develop that atrophy thinning condition, which can affect not only, as I mentioned, the vaginal and vulvar tissues, but also contribute to urinary tract infections, which we want to avoid in our older female patients, and also orgasmic response as well with, with clitoral effects from estrogen therapy too.
Wonderful. Thank you so much. That is all the questions that I see. And as we are over time, I will wrap it up for today. Thank you, Dr. Kurtzer, for
Very
a
welcome.
wonderful webinar and presentation and content and everything that it included. Like I said before, this webinar was recorded and it will be uploaded to our YouTube within the next week. I have the QR code for the survey up on the screen if you prefer to pop open it on your phone. Otherwise, it is in the chat. It will also come in the email later today, along with PowerPoint slides and information if you are wanting to gain nursing contact hours for this presentation. All the information you need will be in that follow-up email. So be on the lookout for that. And with that being said, thank you for joining us today, and I hope to see you all in the future.
Bye-bye. Thanks, everybody.